Take.
Hello, good morning everyone. I'm taking your week 9 clinical session on pediatric HIV. I hope you have seen the two videos which were there in the module 9. The first lecture by Dr. Grace John Stewart and the second lecture by Dr. Anne J. Melvin. Let's start the session. So what are the estimated number of children less than 15 years who are newly infected with HIV? This is 2015, about 1.5 million. We have so many pediatric HIV patients. So let's start with a clinical situation in which there is a 6 weeks old boy is brought to your office for routine care. His mother does not know her HIV status, but the prevalence of HIV in the young women in this area is estimated to be 10%. So next step, what would you take? Could you please click in the answer? Will it be A, test baby with rapid HIV serological test, B, do a clinical examination and check CD4, C, test mother for HIV with rapid test, or test the baby with HIV DNA? So our answer would be test the mother for HIV with rapid test and test the baby with HIV DNA test if mother is positive. What is the age at which we do infant HIV testing? Are they tested at 1 day, 12 months, 3 months, 4 to 6 weeks? What is the answer in this? The second question, you are still answering the first question. Okay, I'll tell you. Basically, 4 to 6 weeks. Infant HIV testing. Why firstly do we need to test HIV? First is the doctor's aim is for early detection, because early detection will put the baby on ART and it improves survival. And CD4 falling and clinical signs appearing, it's too late to save that baby. 4 to 6 weeks is what WHO says. And what are the other benefits of keeping it at 4 to 6 weeks? In a private hospital, you can test anytime, that many amount of money you will be spending. But why we have kept 4 to 6 weeks? One is that it is along with the immunization visit. The first vaccine dose is at 6 weeks, and also it is easy to follow up the mother who is told to come after 6 weeks for a postnatal checkup. So what is there were a lot of studies done whether we should delay starting ART in babies infected with HIV or we should start it early. The SHARE study, which was it was a randomized trial where it was early versus deferred therapy, and babies who had a CD4 more than 25% who were asymptomatic were taken in the study, and CD4 monitoring was done 6 monthly and then 2 monthly for those who were started on ART, and deferred therapy was started in those infants when the CD4 fell less than 25%. So 125 had deferred and 252 had early therapy. So what had happened in that study? It showed that there was a mortality of 16% in the deferred arm. That is, the babies whose ART was deferred, those babies succumbed to the infection, opportunistic infection. It was 16%, and those who were on ART, early ART initiation, the mortality was only 4%, and this difference was very significant. Instead, this study was abandoned midway because they had got this inference that early initiation of ART is very important for survival. Early infant diagnosis is how we diagnose HIV infection in babies less than 18 months. So there are different, what is the approach, the performance, and what are the new guidelines. So let's see what is the testing we do for babies less than 18 months. We do a viral test, that is HIV DNA, and in some situations in developed countries, they also, along with the viral HIV testing, DNA testing, they do the RNA viral load. But more than 18 months, the baby or any child coming older than 18 months, we do a HIV serological test. Now HIV DNA is the collection method is called DBS. DBS is a card test, dried, it's a blotting paper on which 5 droplets of blood is taken from a baby's foot, and this is dried and sent to the lab where it is tested. So the DBS is actually a collection method, while the test being done is HIV DNA. So the result of the test would be PCR for HIV DNA, HIV1 detected, or HIV1 DNA not detected. So if HIV1 DNA is detected, that means the baby is infected, while if HIV DNA is not detected, then we can tell the mother at present there is no sign of HIV infection, but we need to follow up this baby up to 18 months, and the final testing is at 18 months. But remember, if the baby is being breastfed, then we do the final testing 6 weeks after stopping breastfeeding. I won't go through this algorithm. There's the difference between the US algorithm for EID and the NACO guidelines is only that viral testing HIV DNA, one test is enough to start ART according to the US guidelines, while NACO requires 2 consecutive dried blood spot positive results to say that the baby is infected and has to be started on ART. So the next slide is which are the infants which are being tested, and why do we need to test those infants which have unknown maternal status. So if a baby is an adopted baby or is an abandoned baby or whose maternal status mother has died, we should actually be doing dried blood spot in these babies to exclude HIV infection. What is the EID turnaround time? The EID turnaround time means that when the sample was sent and the result comes. In India, of course, our labs take about 6 weeks to 2 months for the result to come, and we keep hoping as clinicians that the baby doesn't become symptomatic by the time the result is available. So what was seen in the next study is that if we wait for diagnosis of HIV infection for hospital admissions of the baby, then the mortality is very high. So we should ideally be detecting the HIV infection in these infants before hospital admissions are there, that is the baby becomes symptomatic. So what is new in infant diagnosis? In 2014, only 50% of all the HIV exposed infants were tested by the second month of age, and this is very low because our aim was that 95% should be tested. And there are innovative approaches. One is that you have point of care virological testing, adding virological load at the thing to speed up identification of HIV infection. Now let's look at another clinical scenario. I'll be doing a lot of clinical scenarios to explain each and every point of pediatric HIV. If you have any questions, please address those in the chat box. I'll try to cover them. PT is a 7-year-old and has been healthy and is in school. Her mother was diagnosed with HIV infection last year. This girl is asymptomatic and is doing well. What are your recommendations? That routine physical examination but no HIV test? B alternative is offer an HIV test. C is conduct a more detailed history on the mother regarding her HIV infection. Yes, I'm very happy to see that people are reading my slides and answering B. Yes, the answer is B. So, just an estimate, how many children are infected with HIV worldwide? What is your answer? I gave it to you on my first slide. If you had seen the first slide, yes, B. 1.8 million children are infected with HIV worldwide. I am very happy that people are listening. This is the distribution of all the patients in the world, and the total is 1.8 million. The range is between 1.5 to 2 million. Older children may get undiagnosed. This is one thing which has worried all the pediatricians, that those mothers who did not get detected for HIV infection during their pregnancy, that is, these unknown mothers have delivered babies, and these are HIV infected babies, and these HIV infected babies will now become symptomatic, get admitted in hospital, and then get diagnosed as HIV. We are missing out on these older children. Second set of older children can be from the known HIV infected who were pregnant, but there was some gap between these babies who were HIV exposed babies for PCR testing. They missed this PCR testing. As I said, if 2014 only 50% of them were tested. So these 50% or half of these, or depends on which country it is, these children will become symptomatic and get admitted in hospital and then get diagnosed as HIV. So we have babies who are born to HIV positive mothers who get detected by a PCR DNA, or we have older children who become symptomatic and are detected with HIV infection. So this is just to tell you that there are babies also who are HIV infected to mothers who are negative, which is very worrisome. That means our healthcare system needs to be improved, because that means this is through the needle stick injuries during immunization or hospitalization or blood transfusions. These are the two things where the mother is negative, but the baby gets HIV infection through blood transfusion or an infected needle. So this set of children also diagnosed usually when they become symptomatic or when they are hospitalized. So what are the signs where we should do HIV testing in older children? Because if you know what is the UNAIDS thing, it's a very ambitious target, that is 90% detected in the community. So if we need 90%, so we must also think about not only the adults but also the older children whose mother has missed on being detected as HIV infected during pregnancy. So how do we test for these older children? We do children of adults in HIV program. Somehow few people have this wrong impression that only test the youngest child, no need of testing all the children. That's a wrong idea we have in our mind. All the children of an HIV infected mother needs to be tested for HIV infection and documented. Mother to child transmission is not 100%. So maybe one of the babies in between may have missed out HIV infection, but that doesn't mean that you don't test all of them. So each and every child of an HIV infected mother needs to be tested for HIV, and they should be documented, and preferably the testing, if it was done 10 years ago, the testing techniques then and now, there's a difference. So if the child is growing well, then it's fine, but if the child is not growing well, please, you can suggest to the parents, because the testing techniques have become better and better over the years. You'll have a lot of scenarios where baby was tested 10 years ago was negative, but now tested it's come positive. That was because of the HIV serology kits and testing quality which was there 10 years ago, and comparatively it's better now. Yes, your question is if younger child is negative even though all children are positive. Yes, it can be possible. So all children need to be tested for HIV, often HIV infected mother. The reason is that mother to child transmission is not 100%. Mother will not give the HIV infection to all her children. The risk factors have already been explained by me in the PMTCT clinical session. So some babies may just get saved with from HIV infection. So whether it is the elder child or the younger child, it is not important. All children need to be tested. This is a very important style. Okay, your next question is 90-90-90 target is till 2020, Dr. Anjali. This slide, please, I would like you to concentrate on this slide. This slide is finding those children who are HIV infected and offering them an HIV testing. How do we go about it? You don't, in India, you cannot tell all parents, please test your child for HIV. No, they will wonder why, how, kyun. So, we need to have a high clinical suspicion in those children who are severely malnourished should undergo HIV testing. Tuberculosis should undergo HIV testing. Tuberculosis and HIV, remember, we remember to test all the adults with tuberculosis for HIV, but we forget about the pediatric tuberculosis patients. They also need to be tested for HIV, and we had a lot of patients who got detected HIV infected when they were infected with tuberculosis. Another is, you will assume that the children of parents who are registered in the ART clinic is been tested for HIV, but if in India you will find out that if you ask them how many children, they'll either tell you only the male child as their child, or they will hide the fact that there are few children in the village also who need to be tested. The children which are staying with them, they have been tested, but they'll not tell you about the children which are staying in the village. They also need to be tested. So I think we need to look back with this 90-90-90 target of UNAIDS. We need to have a relook at the testing of the children of HIV infected parents who are registered in your ART center. The reason is that we must find out, have all the children been tested or not? Okay, your next question is, DBS is only for HIV-1? Yes, at present DBS is only for HIV-1 infection. The kits only detect HIV-1, but always remember that it'll usually it's a co-infection with 1 and 2. Rarely there is HIV-2 infection in the baby. It is rare, but it's very rare. So the present DBS is only, the report which comes is HIV-1 DNA detected or not detected. So another thing is that hospitalized adolescents who have a very high risk, they are drug addicts or they are abandoned children, street children, having neurological deficits, regression of milestones, all these in admitted adolescents in Zimbabwe, they found 14% were HIV infected. So we also, in our children who are admitted in hospital, we must be very sharp in picking up these children who need to be tested for HIV. And they say even immunization clinics in high prevalence setting, there is 10% detection rate of HIV infection. In a child who needs to be tested for HIV, well, US guidelines have different idea. They feel that parents consent is required or legal guardian's consent is required only for children less than 10 years, while in India it is less than 18 years. Counseling, yes, you need to tell them pre-test counseling, post-test counseling. Confidentiality is also important. Abroad, if the child says, adolescent says, I don't want my parents to come to know, you cannot force them for the parents to come to know. Fortunately for India, it is the parents who come to know the result, and they are scared to disclose the HIV infection report to their children. So now we have another case scenario. This is MR is a 21-month-old girl diagnosed with HIV infection. Her weight at 1 year was 50% of the expected weight, and today her weight, that is at 21 months, nearly reaching 2 years, her weight is less than 5% of her expected weight. And she has had diarrhea for last 2 months. So please answer, what HIV related syndrome does she have? This is called HIV wasting syndrome. Okay. What is HIV wasting syndrome? HIV wasting syndrome is, before we diagnose it, we need to do an evaluation. So we do the growth assessment, we do the height, weight, head circumference, infections, any OIs, do a neurodevelopment assessment where we must find out whether her milestones have been achieved on time. Is there any loss of milestones? Is there any regression of milestones? How is her scholastic performance? How does she perform in school? What is her language, this thing? So what is the definition of HIV wasting? HIV wasting is if there is persistent weight loss of more than 10% of the baseline, or when you monitor the child on a growth chart. See, in US they use CDC growth charts, in India we use WHO growth charts. So if you are plotting a HIV exposed baby on a growth chart, you will come to know if the baby is lost more than 10% of its baseline weight, or it has crossed 2 percentile lines below, or it is less than 5th centile on weight for height chart on 2 consecutive visits with diarrhea and fever for more than 30 days. So the Dr. Nazia, fever, diarrhea and weight loss is the right diagnosis for HIV wasting. So in HIV wasting not to occur, what is the WHO nutritional care plan? They say that normal children who have normal growth standards, they need 10% additional energy requirement than non-infected children. If there is some amount of weight loss, but this weight loss is more than 5%, but there is no evidence of visible wasting, that is, it is moderate malnutrition, and there are comorbidities, then you need to give 20 to 30% additional energy. But if there is severe malnutrition, visible wasting, edema, then this child requires institutional management. The child should be admitted, because giving 50 to 100% additional energy would be difficult. Therapeutic foods would be needed to be given, and other infections need to be ruled out. This is, though the graph is not very clear, but I would just like to tell you this much, that younger the age at initiation of ART, more rapid is the growth reconstitution. That is, even if the child is moderately malnourished, but if as early as you start ART, the response to ART is seen as a magical thing for the mother, because the child starts gaining weight, the child starts gaining all the milestones, the child starts gaining height. What they have shown over here is that there is a great amount of change in both height, weight and other developmental milestones also. Now case 4, let's see a scenario. 3-month-old with HIV. What is the likelihood of dying within 1 to 2 years? You'll always have a mother whose DBS is positive. That mother will ask you, how long will my child live if I don't start this baby on HIV ART? So the answer is 40 to 50%. Yes, 40 to 50%. I'm very happy all of you are answering this. Now, this is just a graph to show you that the time to from HIV infection to AIDS in adults and children. This is a very important slide, HIV RNA levels in infants compared to adults. So this is the reason why we insist on early ART initiation. The reason is that in adults there's a rise of viral load and a sudden fall of viral load, and thereafter it plateaus till a second rise comes when AIDS manifests, AIDS defining criteria manifest. But in children the viral loads remain high for up to 2 years. So even if the child is not symptomatic, because of the high viral loads, even a single opportunistic infection can kill the baby. So do not wait for the baby to get infection to start ART, because if the baby gets admitted in hospital, gets infected, you will not be able to save that baby from that infection. The reason is that the HIV RNA levels are very high, even if the CD4 counts are high, but the viral load is so high that the baby is not able to fight any opportunistic infections. Hence, early ART initiation is very important to reduce mortality in the first 2 years of life. This is the reason why we do the dried blood spot testing to detect HIV infection. We do it to do early detection of infection so that we can start ART and the baby doesn't get any infections or hospitalizations. So this is a slide just to show you various studies show various different things for 1 year mortality. What are the risk factors for rapid progression? Low CD4 count, high viral load, in utero infection, that is the baby got infected during pregnancy and the virus replication was very high at the time of birth. These babies, vis-a-vis babies who get infected through breast milk, their progression is not so rapid as those babies who got infection, HIV infection from the mother during pregnancy. Another risk factor for getting HIV or rapid progression of HIV in babies is low maternal CD4 count and anemia during pregnancy. Maternal deaths, low birth weight babies have more chance of having a rapid HIV progression, and poor infant growth. So we have another case scenario. I would like you to tell me the answer. RY is a 6-week-old born to an HIV infected mother. The PCR DNA test positive. Mother received PMT-CT, that is, it received prophylaxis in pregnancy. How should you manage this child? So what is your answer? I've only got one, Dr. Nazia. I'm waiting for a few seconds. Okay, another one. Some more answers, then I'll give you the answer. You're both right. It is C. Treat immediately with a PI containing regimen. Remember, in US, one PCR DNA positive, they start ART. In the NACO guidelines, please remember, is different. We need to do one PCR DNA is positive. We need to immediately repeat that PCR DNA on a different sample, and if that is also positive, we start the baby on ART. So what is the infant response? So there was a lot of discussion whether we should give nevirapine based regimens or we should give PI based regimens. See, PI based regimens are very expensive. The PI needs to be kept in the fridge. Lots of logistic issues. At present in India, we do not have syrup lopinavir in certain centers, and we are breaking down tablets of adult lopinavir and giving it to babies where the drug levels may be very different depending on how you break the tablets. All these issues are because it's a very expensive drug. So there were lots of studies done, and they found that if an infant who's been given single dose nevirapine for prevention of mother to child transmission, nevirapine prophylaxis has been given, that infant, if it becomes infected and is put on a nevirapine ART, the chances of viral failure is 76.9. Okay, while if we start this baby on a PI regimen, there are two reasons for giving a PI regimen. One is that these babies who are infected have a very high RNA load, and nevirapine is not a very good drug to act against this high viral load vis-a-vis when compared to a PI, which is very good at reducing this high viral load. Secondly, nevirapine resistance of treatment failure in these babies to nevirapine is higher, whereas if you start on a PI based ART in these infants, the virological failure takes time to occur. This is what is given in the study. So PI based regimens, two positive things. One, it looks after the high viral load which is there in these babies. Second, the treatment failure is postponed if we use a PI based regimen, and that is why we in our NACO guidelines we say less than 3 years babies are to be put on a PI based ART. This is a famous Mississippi baby. I think all of you must have heard. They were given 30 hours of ART was given, and after that there was withdrawal of ART, and thereafter the baby was tested again and again, and there was lots of euphoria that there is no HIV infection, and giving excellent prophylaxis during pregnancy, during delivery will help in finishing the HIV infection. But remember that after 27 months there was return of the virus. So viremic relapse after HIV remission in a perinatal infected child is common. So if your PCR DNA is positive but the serology is negative at 18 months and you've started the baby on ART, please continue the baby on ART, because you do not know when there will be return of the virus and the serological test will again become positive. Again, I would like to tell you another case scenario. A 6-year-old has been receiving ART for 4 years, lives with widowed mother and 3 siblings. Now this 6-year-old doesn't know about the HIV infection. So when should he be told about HIV? Who should tell him about HIV, and how should he be told about HIV? So basically this case scenario is to discuss disclosure. So disclosure would be, this is a study where they've studied reasons for non-disclosure. Most parents say that 60% of those who are above 10 years did not disclose the HIV status of their kids to the parents did not disclose the HIV status to the kids, that you are got HIV infection and what medicine you are having is for HIV. Only 19% disclosed it. Why? The reasons for non-disclosure these parents gave was they are too young to understand, the child will become depressed, unable to keep a secret, fear of questions and transmission, fear of discrimination. This is very common in India, is child will blame parents. We had children who were adolescent children who would turn around and shout at the mother that because of you I have got HIV infected. You are responsible for this infection. That is another reaction which parents really fear and do not know how to tell the child. That is another way. So, pediatric HIV disclosure is a big counseling issue. And what are the barriers? See, I'll give you an example of a mother of a 10-year-old. You know, I think I have failed because I think the child should be disclosed about HIV status at 6 to 7 years. That is my opinion. Though I don't have the courage to disclose it to my child up till now, because as the child grows it becomes harder to disclose, and if I disclose it, it will just kill him. This is what a mother of a 10-year-old said. Another mother said, even when he tested TB positive, I told him because it was just TB. But for this disease, a parent sees this as death, and if you disclose it, it is like killing your child or stabbing with a knife. But these are wrong ideas which parents have. In the sense, it is not killing. You're not giving a death sentence to the child by disclosing the HIV status. Actually, you are counseling them to have good habits, look after their health, become more responsible, and understand the disease. And HIV is no longer a death sentence as was perceived by parents previously. Another two experiences. When the doctors told him, he was shocked. For 2-3 days when he was at home, he was just sitting still. Don't people get this problem through having sex? But I have never done that, he asked. This was caregiver of an 11-year-old. How do you explain to that child, 11-year-old, that you got infection from your mother? Another 10-year-old told her father, Daddy, just buy me a watch. And I bought her that, and she never takes it off her hand. So when it's 7 o'clock reaches, even if there are visitors, she will take her medicine in the kitchen, and if it's just family, she will take the medicine. She doesn't mind. So this 10-year-old has confidently accepted her disease and has understood her disease and is now taking her medicines regularly on time. So these are the various techniques how we can do pediatric HIV disclosure. Basically, 3-4 steps. You must have a gradual disclosure process, and initially the child will not understand what exactly is HIV. Gradually, as the child grows up, the understanding will increase, so it has to be a repeated counseling effort, and it should be a supported process. Each time the child comes after disclosure, you must explain to the child how the child should behave in school, because the child will have lots of questions about disclosing HIV to his friends, to the school children, to the teachers, friends. By encouraging disclosure, we must help the caregiver and build relationships with the caregiver and the child. This is the time. So it has to be an ongoing support and an ongoing counseling sessions which need to be done. This is a NACO guideline which I have picked up because I wanted to tell you about what are NACO guidelines on counseling and disclosure of HIV infection. In NACO, we feel that as soon as the child is able to understand, that is 10 to 12 years. And who should tell the child? NACO says that parents should tell the child, but if the parents are not confident about telling the child, then they should take support of the counselors to disclose it to the child, and repeated counselings with the counselor needs to be done to explain the child in each visit what is the implication of this infection. So that is why there is something called a short-term disclosure and short-term effects of disclosure and long-term effects. So the long-term effects require continuous psychological support. Another case scenario. Mary was started on ART at 1 year old. Her mother wants to know what you think is her prognosis. Will she grow up to her teens? If she does grow up, then what will be her scholastic achievements? Will she perform well in school? These are common questions which are asked by our parents also. In our center, the parents used to ask, will she survive? Can she get married? How will she perform in school? So our answer is, so what is the long-term outcomes in adolescents who are perinatally infected or those who are infected by mother-to-child transmission? So they survive up to 15 years without ART. Okay. If ART is given, the survival is even better. They have a normal growth. You have comparable educational achievements if started ART in time. The poor scholastic aptitude and performance is seen in mostly those babies who have acquired HIV infection during pregnancy, because by then the HIV viral load is so much and the HIV enters the brain and decreases, affects the brain growth and development, and they have cognitive defects, and they are slow learners, labeled as slow learners. So but if the baby is diagnosed infected and started on ART, they have a good life, their growth patterns are good, they will be able to achieve the height which their parents have achieved and also perform well in school. What is your country's PMTCT coverage, please? We hope to be 90%. So by 2015, 90% decrease in HIV, 30,000 infections, less than 5% transmission risk, and reducing HIV maternal deaths by 50%. Now we'll talk about few clinical scenarios and what is antiretroviral management in children. Any questions up till now? I can take a 2 minutes break to answer any questions about HIV diagnosis in infants, HIV diagnosis in adults, what are the tests to be done. Should I progress to the next half of the presentation? Okay. So we have a 5-month-old baby who has history. 2 months ago, he had a history of respiratory distress. It was a term infant. Mother had good perinatal care. Mother was tested HIV at 5 months of pregnancy. The baby was well till 3 months of age. Then last 2 months, the baby's been having history of poor weight gain, vomiting, occasional cough, some congestion, difficulty in breathing, occasional episodes of fever. In the last 2 months, they have visited the doctor 5 times. Respiratory rate is 78, temperature is 38.5. Lung examination shows a few basal creps. Intercostal retractions, nasal flaring, oxygen saturation is 85%. So, can you please tell me what is your diagnosis? This is the X-ray chest of that child. You can have a look at this X-ray chest. So, what is the diagnosis? Okay. Dr. Nazia says pneumonia. Another doctor says PCP. Another says pneumonia, PCP. Okay. We would say pneumonia with severe hypoxia, which is called severe pneumonia because there is hypoxia. But pneumonias are usually acute onsets. And PCP is also a pneumonia. That also is an acute onset. But this picture fits in with the X-ray, fits in more into PCP. Let's talk about pneumonias in HIV infected children. There's a high burden up to 20% of all pneumonia cases in children and 60% of pneumonia deaths are usually in HIV infected children. So pneumonia is the commonest opportunistic infection which occurs in a HIV infected child. These pneumonias usually are bacterial. They are strep pneumonias, staph aureus pneumonias. Staph aureus can also lead to lung abscesses and empyemas. PCP is a very common pneumonia which occurs in less than 1 year of age. The commonest infection occurring in less than 1 year is a PCP pneumonia. So, Mycobacterium tuberculosis, yes, that is also there, and viral pneumonias. These are the 4 differential diagnoses in this baby. What are the risk factors for mortality, or what are the chances of a baby HIV infected child who has pneumonia? One is if there is HIV co-infection, if there is severe pneumonia as per WHO definition. If the age is less than 2 months, there is high chance of mortality. If there's PCP, it's very high chance of mortality if it's PCP. Severe malnutrition and any chronic underlying lung disease will increase the risk for the baby to die following a pneumonia infection. Now let's talk about PCP. PCP is pneumocystis jirovecii pneumonia, which is the commonest pneumonia which is seen in infants infected with HIV. Its highest incidence is between 3 to 6 months and occurs usually less than 1 year of age. Mortality is very high. The only way to diagnose it is by taking a induced sputum and testing it for PCP organism, or take a bronchoalveolar lavage and test it. BAL is a better BAL is bronchoalveolar lavage sample is a better test for PCP. Nasogastric aspirates will also help, but it is the empirical treatment in infants with severe pneumonia where we start on PCP treatment. So how do we start with PCP treatment? In this child, what we would have done is started the baby as thinking it to be a bacterial pneumonia. Start on antibiotics to cover the bacterial pneumonia. See for response in 72 hours. Send all the investigations. If we find that the baby responds in 72 hours, that means it's a bacterial pneumonia clinically. And if the baby doesn't respond, then think of PCP and empirical treatment. If the baby's hypoxia persists, with PCP treatment would be the mode of management. So, what is the WHO guidelines? What is empiric treatment of HIV infected infants and children with pneumonia? So, WHO says it divides it into not severe pneumonia and very severe pneumonia. Now severe pneumonia more than 1 year and severe pneumonia less than 1 year. So the antibiotics differ between all this. Okay, and very severe pneumonias require hospitalization and intensive care. What are the preventive measures which we can take to avoid, when we have said that the commonest opportunistic infection in children is pneumonia? So let's try preventing this, and the best way to prevent is to give vaccines. So what are the vaccines we need to give HIV infected babies? But remember, their CD4% should be more than 15% to be giving any of the live vaccines. If the CD4 is less than 15%, then we start ART, wait for reconstitution, let the CD4% come up, then give the vaccine. Because the uptake of the vaccine also depends on what is the immune status of the baby. Giving a vaccine is not important, but uptake of that vaccine for it to be effectively preventing the disease is more important. So what are the infections, immunizations we can give? We can give pneumococcal conjugate vaccines. We give hip titer. That is why hip titer is very important. It should actually gradually be included in our immunization program. Some states have included it, some states have not included it. Influenza vaccine, it's available in the market, should be given after 1 year of age. Measles vaccine, already there in the immunization program. Pertussis, already there in the immunization program. Nutritional support is very important because pneumonia with severe malnutrition, mortality increases. Early ART initiation will increase the CD4% and will build up the resistance and will help in the baby not getting opportunistic infections. And the most important thing which will help these babies, HIV infected babies, is Septran prophylaxis. Septran prophylaxis is the one most important step which will prevent these children from getting opportunistic infections, especially pneumonias and diarrheas. So all babies HIV exposed at 6 weeks, along with doing the DBS, we need to start on Septran prophylaxis and continue till their HIV is excluded. Those who become HIV infected, Septran prophylaxis is continued up to 5 years of age. The question everybody asks is, what happens at 5 years of age? Why only up to 5 years of age? So the answer is that the baby's immune system is very immature and it gradually grows. So you'll find lots of babies get infections during the first 2 years of life, and gradually the number of infections reduce thereafter. By 5 years, their immune status is good and they have their ability to fight infections. So at 5 years of age, if the CD4 counts are good, we can stop the Septran prophylaxis. But all children HIV infected need to be on Septran prophylaxis up to 5 years of age. So what is the WHO guideline? It says what I just explained to you. 4 to 6 weeks until HIV has been exposed. All HIV infected children less than 5 years of age. For children more than 5 years of age, if you have WHO 3 and 4 disease, we need to give Septran prophylaxis. If the CD4 is less than 350, we need to be giving Septran prophylaxis. And if living in a setting with endemic malaria or any serious bacterial infections, or the child has underlying lung pathology like bronchiectasis where the child is susceptible for infections, you can continue the Septran prophylaxis. So another case scenario to discuss, there's a child who's not walking. Parents are very concerned that the child is 2 years of age and it's not walking. The baby was diagnosed HIV infected at 14 months of age. The viral load is more than 1 lakh copies. CD4% is 17%. Clinically, there is low tone, increased lower extremity tone, brisk deep tendon jerks. There's ankle clonus. So can you please tell me what is the cause of this child's developmental delay? Is it congenital infection? Is it in utero drug or alcohol exposure? Prematurity, recurrent pneumonias, HIV and encephalopathy. Very good, it is HIV and encephalopathy. I'm very happy. So what is HIV and encephalopathy? This was seen before ART used to be started. So it's progressive. There is loss of previously acquired developmental milestones. There's decline in cognitive ability, acquired microcephaly. There is motor dysfunction. There is hypotonia, spastic diplegia, oral motor dysfunction. They found a study was done in South Africa where babies of between 18 to 30 months HIV infected children were studied for cognitive delay, and they found that 97% of them functioned below expected age and 82.5% with global language delay. So lot of cognitive delay and lower cognitive functions and controls are seen in HIV infected children. This again specially occurs in babies acquiring infection in utero during pregnancy. So that is why our focus is that we should actually get mothers tested before they become pregnant, because once the mother gets pregnant and the baby gets infected in utero, the mortality may reduce because of starting ART, but the morbidity still remains high for in utero HIV infection in babies. So what is the age at start of ART? So this was another study which showed that if you start ART early, there is a lot of developmental gains, and vis-a-vis those babies who are deferred ART. Okay, so those children showed improved neurocognitive outcomes when they reach school age. So again, another positive pointer that we must start ART early. Yes, I agree with you, Dr. Nazia. Early ART and physiotherapy and speech therapy is the treatment for this child. Early ART itself will help the child regain all these milestones it has lost, and physiotherapy to look after its increased tone and disabilities which may occur if it's not addressed in time, similar to the speech therapy. That has to be addressed in time. Thank you. Very good. Third case scenario, 8-year-old boy with failure to thrive, weakness, fever and cough, brought in by his sister. History of both parents have died. History is of chronic cough, intermittent fever, weight loss, too weak to walk. So what does this child have? So we have 4 differential diagnoses. One is tuberculosis, one is bacterial pneumonia, one is fungal pneumonia, and what are the others? Viral pneumonia. So what is the answer? Tuberculosis. So in high HIV, in high TB prevalence areas, HIV infected children have up to 6 times the chance of getting TB infection and 10 times the mortality. So in some areas, 25 to 40% of HIV infected children are diagnosed only when they are co-infected with TB. Sorry. So tuberculosis is very common in HIV infected children, and that's why I'll talk about IPT is very important in children. So what is HIV and TB in co-infection? They are frequent co-infections. It increases morbidity and mortality. It's hard to diagnose, especially in children, and it's hard to treat because children anyway take a lot of time this thing in taking medicines, so the pill burden increases. You have TB treatment, you have ART drugs, there may be drug interactions also. So let's see what is diagnosis of TB in HIV infected children. So first thing is clinical symptoms. History of contact is very important in these children. Must ask this history of contact of tuberculosis in any of the family members or neighborhood. Skin testing is less reliable. Tuberculin test though done by each and every doctor in each and every patient who's suspected to have tuberculosis, but it's less reliable. Diagnosis frequently is presumptive. How do you diagnose it? Usually you see that if you treat it as a bacterial pneumonia, it is unresponsive to antibiotics, the child is started on tuberculosis. Weight loss is there, chronic cough is there, history of persistent fever, contact history is there. Empirical diagnosis of tuberculosis is done. But is this right? It is not right. For the simple reason that in HIV infected children, what looks on a radiological picture as tuberculosis may not be tuberculosis. It may be some severe pneumonia or a difficult treating pneumonia. It could be a fungal infection. It could be bronchitis with superadded infection. So we need to do a proper thorough investigation, and preferably please refer these children to a pediatrician who can assess the child, and if possible do bronchoalveolar lavages to see for tubercular infections. So diagnosis of pulmonary TB in HIV infected children requires a very good pediatric pulmonologist to help you out to reach. Each and every infiltrate on an X-ray is not tuberculosis, please remember. So sputum, it's very difficult to get a sputum in a small child. You can only get it in more than 7 years of age. Most of the time when you tell them to take out sputum, they take out saliva. Induced sputum is a very good source, but it can only be done in the hospital setting, and the child needs to come at least 2 consecutive days empty stomach to the hospital, and you need a doctor, you need a pediatric resident to do that induced sputum. But it's a good sample. Gastric aspirate, very good sample, but again you need to come empty stomach to the hospital on 2 consecutive days, and gastric aspirate sometimes need to be admitted in small, if the baby is small, because the baby will require frequent feeds. TB diagnosis, gene expert is come up in a big way. Its sensitivity is 95% in smear positive children, which can be either sputum, bowel, gastric aspirate, induced sputum. All the samples can help in this gene expert. Also extra pulmonary samples like CSF, lymph node aspirates, they can also be tested for expert MTB and Rifa resistance. So this should be used as initial diagnostic test for HIV infected children suspected of having TB. So please do this test in all children where you cannot find out any diagnosis. Yes, effusion tapping, if there is an effusion, please aspirate the pleural effusion and send that collection for gene expert. Other samples which can be tested in children are lymph nodes. If it's a bone TB, aspirate from there. Stool, unlikely, but it's under study whether it will help or not. But yes, lymph node samples, CSF, pleural fluids, ascitic fluids, sputum, gastric aspirate, induced sputum, all these samples should actually be sent for gene expert. So now, what is HIV and TB treatment? There's always a confusion when we should start treating these children. TB treatment, TB will kill the patient. So TB treatment has to start first. But ART, how long should be the difference in time from start of ATT? How long should we wait to start ART? There are different views and different these things, but NARCO guidelines say that if the CD4 is less than 50, we should start simultaneously. But if the CD4 is more than 50, then we can wait for up to 2 weeks to 8 weeks. But by 8 weeks, we must start ART in a HIV infected, TB co-infected patient. What is the ART regimen? In less than 3 years, this triple NRTI is one choice, but it's rarely available. We are giving PI based regimens in less than 3 years, so we need to do super boosting of the ritonavir in these patients and avoid using triple NRTIs. Triple NRTIs was there previously, but triple NRTIs is not a very good doesn't have a very good virological suppression, and with these children who are less than 3 years have a very high viral load plus have TB co-infection, the virological suppression of triple NRTI is vis-a-vis super boosted PI. The winner is super boosted PI based ART. In more than 3 years, you can easily use efavirenz. So we give efavirenz with 2 NRTIs. See, triple NRTI should be kept as the last option where nothing is available and you need to give something. That is why it's written need to switch off triple NRTIs as soon as possible. I would say avoid using this and preferably take a PCOE's opinion before starting any child on a triple NRTI, because the viral suppression following a triple NRTI is not effective. We'll be giving ART, but its effect will not be there. So before I shift, so we start TB treatment first. There should be no doubt. TB kills the patient, so TB treatment first. HIV treatment after 2 weeks. You can delay it if the patient is having some toxicity, but preferably before 8 weeks. And those who are CD4 counts are very low, less than 50, the benefit is to start both together. Yes, I agree with you, Dr. Nazia, as early as ATT is tolerated. So what do we do in a PI-based ART with TB? We use super boosted lopinavir when it is co-administrated with rifampicin, because rifampicin and lopinavir both are enzyme inducers and the levels will get reduced. So ART will not be effective, ATT also will not be effective. So what is the prevention of WH? How do we prevent tuberculosis? If it's so common in children, Dr. Parvinder, rifabutin use in children less than 10 years is not studied as yet. Rifabutin can only be used in more than 12 years of age. Less than 12 years of age, the dosage and the use, it's a research question which is being done. Maybe in a few years we'll come to know. Like tenofovir previously was not used in children. Less than 10 years now, America has started using tenofovir in children also. Similarly, rifabutin, at present, Indian guidelines, less than 12 years it's not used. So we can't use rifabutin in children. So what do? We do super boosted PI based. Once we do super boosted PI based regimen, we can give it along with rifampicin. You don't need to give rifabutin with super boosted PI based regimen. Is that clear? If we need to give PI based regimen along with rifampicin, we need to super boost the ritonavir in 1:1 ratio. Okay, that will help in maintaining the levels of rifampicin and maintaining the levels, most importantly, of the ART. That's why we super boost the ritonavir to make it in the equal ratio of lopinavir ritonavir as 1:1. In that case, rifampicin can be given along. Okay, what is the prevention? One is that all infants and children should be screened for active TB. You must ask a history of exposure of parents, poor weight gain, fever, cough, have a thorough clinical examination, and if active disease is excluded, we must put this child on IPT for 6 months. Very important. The only thing which will help save this child from getting tuberculosis is this INH prophylaxis. And while you're giving the INH prophylaxis, you will also be starting this child on ART. So by the time the INH prophylaxis would have got over, the child's ART would have become effective and the chance of getting tuberculosis in this child will be reduced markedly. So the one step of prevention which is very important and thankfully has come to India is INH prophylaxis. What about prevention US guidelines? So US guidelines you need to know because you're doing a course from US. Screen yearly with TST is a tuberculin test and IGRA or IGRA if it's more than 5 years of age. If you have a positive screen, that is either of these tests are positive, or you have a history of active tuberculosis in a relative or in a close family member, then we need to rule out active TB and give INH prophylaxis for 9 months. Okay, US guideline says you give INH prophylaxis only if there is a TST or a IGRA positive or there is exposure to TB in the family. First, rule out active TB. If there is no active TB, put the child on INH prophylaxis for 9 months. And in US, they screen yearly with tuberculin test or IGRA. IGRA is done in more than 5 years of age and tuberculin test is done in less than 5 years of age. So, any more questions on this? I will go ahead to antiretroviral therapy in children. Okay, so there are lots and lots of ARTs which are ARV drugs which are available. Certain can be given at certain age, certain cannot be given. You can see this child making a face. Most of the drugs are bitter in taste. Loponavir syrup is very bitter in taste. So this is the timing when these drugs can be given. Rohini can be given at birth. These two drugs we've stopped using, so I'm not going to talk about them. Lamivudine also can be given since birth. Abacavir ideally after 3 months of age. Tenofovir DF, this is a new formulation of tenofovir. It is given, can be given in more than 2 years of age. It's not available. The next tenofovir is given in more than 35 kgs of weight. NNRTI is nevirapine. Of course, we give nevirapine prophylaxis. What is Dr. Nazia saying? Ma'am, it's too much difficult to rule out active TB in pediatrics. So eligibility of IPT can't be judged. So try your best. If there is no evidence of tuberculosis in the child, if there is no history of contact with the child, start the child on IPT and see ahead. But I would suggest that in children less than 5 years where it is very difficult to diagnose, as you're saying, you can take an opinion of the pediatrician that please have the pediatrician have a look and say, okay, that at present clinically there is no evidence of tuberculosis, so we can start the child on IPT. NNRTIs can be given. Efavirenz cannot be given in less than 3 years of age. Okay. Integrase inhibitors. Raltegravir can be given after 4 weeks. See, these all drugs are not available in pediatric formulations at present in our country, but they can be given in pediatric. This third line drug, which 2 out of this 1 is available, they can be given in more than 30 kgs of weight. Is PI based. What we have in our country is loponavir, ritonavir. Azatanavir cannot be given in less than 3 months. It can be only given more than 3 months. Darunavir can be given more than 3 years. Fusion and entry inhibitors not available at present in our country, but these are the ages where they can be given. So what is the yearly mortality in children? You do a long-term follow-up children started on ART. In 1994, the death rate was 7.2 of 100 patient years, while in 2006 it has improved to 0.6. So the mortality rate has reduced markedly. There was another study where 6,000 children in South Africa were treated with first-line ART. More than 80% showed virological suppression after 3 years of ART. 7.7 mortality usually occurs in the first 3 months of starting ART. Remember, that is why, and most of these mortality reasons are opportunistic infections. What are the risks for mortality among children who are being initiated on ART? That is greatest likelihood of death within first 6 months of treatment because of opportunistic infections. Those children who are malnourished, they have a higher risk of mortality. Those who ART is started when the CD4% is low have higher risk for death. Baseline anemia is seen to be another risk factor for increased mortality in these children, and a high baseline viral load. We do not do a baseline viral load, but it is seen as in adults, any child with a high baseline viral load has increased chance of having mortality during the first 6 months of ART. These are the US guidelines for starting ARV treatment. In India, we follow treat all, but treat all means we have to prioritize. So this is what is the priority, that all ages, those who have AIDS and significant symptoms or clinical stage 3 or 4 should be priority should be started. Children less than 3 years of age on priority. Children less than 1 month of age, HIV infected, urgent treatment. This is what is the prioritization. We need to start everybody on ART, but how do we decide who's more important to be started? This is what is being explained over here. Those children whose CD4s are low need to be started on ART as soon as possible, but that doesn't mean that you skip the steps of counseling. So the child will be investigated for tuberculosis and other opportunistic infections will be screened. The child will be started on Septran prophylaxis. 3 counseling sessions will be done. Caregiver will be identified, and only after that the ART is to be started. It doesn't mean that you start the next day. If in such cases, if you are in a hurry to start ART, there is more chances of non-adherence later in the first 1 year of life. So proper counseling, caregiver counseling, identification of opportunistic infections, Septran prophylaxis, all these important steps. But yes, priority of who needs to be started before who. This is what is given in this place. Okay, now what is WHO guidelines? WHO guidelines are, as it is says, that treat all infants, children and adolescents. But who should be priority? All children less than 2 years of age with WHO 3-4 stage or CD4 less than 750. Other those small children who are less than 5 years who have a CD4 less than 25%. And the last priority is children who have CD4 less than 350 in age more than 5 years. So most important is start all children less than 2 years on ART. Otherwise you lose these children. This is the US guidelines for first line ART. If you can see that, lopinavir cannot be used in the first 14 days of life. So that's why they have given nevirapine in the first 14 days of life. But remember, we don't diagnose babies having HIV infection before 3 months of age. Usually 6 weeks we send the DBS. By the time the DBS comes positive, we repeat a sample of DBS, and by the time that comes positive, the baby is around 3 months of age. So we also follow the same guidelines, that is, you give 2 NRTIs, in which lamivudine is one of them. The choice between zidovudine and abacavir depends on how much the HP is. If the HP is less than 9 grams, we give abacavir, lamivudine, lopinavir, ritonavir. If the HP is more than 9 grams, we give zidovudine, lamivudine, and lopinavir, ritonavir. So all children less than 3 years are started on a PI based regimen. In US, they also have a regimen where raltegravir is started. Then they are using these, what we have as third line for adults, they are using. In more than 6 years, instead of using lopinavir, they are using azetonavir. Please have a look at these regimens. But remember our NACO guidelines. Don't get confused with these. These are just for knowledge. We follow what NACO says. NACO says less than 3 years, it is 2 NRTIs with lopinavir, ritonavir. More than 3 years is 2 NRTIs and efavirenz. If the child is more than 12 kgs or more than 30 kgs, instead of giving zidovudine or abacavir, we can put that child on tenofovir regimen. So all children more than 12 years of age and 30 kg weight, instead of 1 NRTI, instead of being zidovudine or abacavir, can be tenofovir. This is WHO, what I was explaining to you, exactly this. More than 10 years and 35 kgs, we can give tenofovir in these children. Efavirenz can be given, should be given. The only place where we use lopinavir is less than 3 years of age. So what is the monitoring we do while on ART? We do a clinical assessment, growth assessment, development assessment. We note down the number of opportunistic infections they have, note down the ART toxicity they have. It is seen that children tolerate ART much better than adults. They have less side effects than adults. Probably the mothers give them food along with the ART, and they are happy-go-lucky children, so they do not have so many toxicities, though the commonest toxicity is usually anemia. Adherence assessment is a very big task in children because it is the caregiver who gives the medicine, so the assessment is actually the adherence of the caregiver in giving the medicine. So counseling of caregiver in pediatric ART is very important. Dosage adjustment, please remember that see the weight of the child every visit. Reason is that you need to adjust the doses depending on the weight band of the baby. As I told you, as soon as you start ART, they give a magical response in gaining weight and height. So the dose adjustment has to be done. You will see a very good weight gain. Accordingly, the dosage of the ART drugs need to be changed. I hope all of you have pediatric drug charts in your ART centers. Please refer them and do the dose adjustments. Lab testing, very important. We need to do CBC, creatinine levels. We need to do LFTs. US guidelines says HIV viral load. We do not do viral load. We do CD4 counts. So CD4 counts in children less than 5 years, we need to do CD4%. Now another case scenario, a 3-year-old girl was diagnosed in infancy and has been fully suppressed on chemotherapy since 2 months of age. Suddenly, accidentally, I don't know how, the child got a HIV serology, that is antibody testing done, and the results were negative. So is this child HIV infected? Please just answer the question. Okay, I'm very happy to see that. Remember, there is lots of HIV antibody bodies, especially in those children who are started ART in infancy. No, you cannot say no virus, so no antibodies. The antibodies are so low that they are not detectable by the test. That is the reason. Virus is still there, but the viruses are so low that the antibodies are also in low titer and they are not detectable. Yes, less virus, agreed. So remember this. So there will be some parents who say कि अब तो बच्चा ठीक हो गया, आपने ART शुरू कर दी, now we can stop the ART because now the HIV test is negative. But remember, that could be because the antibody titer is so low that is not getting detected. But the baby is still HIV infected and the baby does need to take ART. Now, what are the causes of ART failure? One is resistance. Maybe you've given a wrong regimen. Why do you say wrong regimen? Baby got nevirapine at birth for prophylaxis and the baby got diagnosed as HIV infected and the baby was started on a nevirapine or a efavirenz. Efavirenz so you won't give in less than 3 years, but a nevirapine based ART, the baby has developed resistance to nevirapine and has developed ART failure. Pharmacokinetics. You have not increased the dose of the ARV drugs as per the weight. That is why I was saying it's very important to have a pediatric drug dosage chart on your table while you're treating a child and see the weight every visit so that you can change the dosage, pediatric dosage. Adherence. Adherence is very important in pediatric ART failure. As I told you, adherence is actually the caregiver's adherence, because if the caregiver forgets to give the medicine, the child will not know when the medicine has to be given. So adherence is a big issue in ART failure. HIV resistance after failure on first line therapy. There were lots of studies which were reviewed and they found that 26% of children failed. 90% of children had at least one resistance mutation at failure, and longer time on treatment increased risk of resistance. And these children who've been put on ART since birth are going to develop sometime or the other ART failure. But our aim is that we postpone this ART failure to a later date by ensuring adherence, giving the right dose of ART. Let me go back to the previous slide. If we look at these three causes of ART failure and we address these causes, we will postpone the ART resistance to a later date, especially in those babies who have been started ART in first year of life. So these are the dosage which are there in ARVs. Vis-a-vis what is the adult dose and what is the pediatric dose. Now I found this slide very important because we are crushing tablets and giving whole tablets. The pharmacokinetics of crushing tablets is always less than that, but then we have no choice. Okay, Dr. Nazia, if less than 1 year you start ARV as per below 5 years and now age is 7 years and CD4 decline, how can we judge for failure? In children, look at the clinical status. They become symptomatic earlier as vis-a-vis adults become symptomatic. Adults' clinical symptomatology is the last thing in ART failure, but children start getting symptomatic. So if the child is getting symptomatic, is showing. So we look at a CD4 decline. If the CD4 is declining, please refer to SASEP and get a viral load testing done. Only that can tell you whether the CD4 decline is a normal immunological decline due to ART failure or due to age-related immunological CD4 decline. So we each in pediatrics ART failure, we need to actually look at the whole picture, how the child is growing, how the child is achieving milestones, how is the child clinical infections and clinical progress, and if you still feel that the CD4 is declining, please give a SASEP referral, and if your SASEP doesn't accept referrals without a PCOE or a pediatrician's thing, you can send a opinion to PCOE for a expert opinion to see. But the only actual way to find out is by doing a viral load testing. This is the asymptomatic baseline CD4 1500 12% and now 700, but no role of percentage. No, percentage can help you even afterwards. If the percentage has increased from 12% to 25%, it's a good percentage rise, though the CD4 has fallen. So both things you need to look at. And though we are starting at high CD4%, CD4 counts, and with age the CD4 count falls, but the CD4% does not fall. CD4% usually doesn't fall as the age grows. Okay. This is a drug dosage chart. If you all can send me on the iTech mail, you can tell us if you all don't have, then NACO does have a very good pediatric dosage chart which is available, which can be printed and laminated and kept in the ART centers. This is just a graph to show that adherence is very important if you want to show virological suppression. So now let's talk about adherence. What are the issues to be considered? What is the stage and age of the child? Who is going to give the medicine? What is the parents-child interaction? What is the psychological environment, social environment? The pediatric formulations are very bitter. Caregiver factors, yes, that's the most important issues which is there in adherence, is the caregivers factors. Is the caregiver infected with HIV? That will be another issue. If the caregiver is got some OI like tuberculosis, if the caregiver is educated or not, all these are important factors. So what are the ways to support adherence? It is the ART center staff and the counselor who need to support in adherence, because without adherence, viral suppression will not occur. So understanding of medications, what they are, how they work, expected side effects, and how to handle them. This is very important, because what happens is, as soon as the child starts vomiting or develops some toxicity, the first thing the parents do is stop the medicine. But they have to be told that you don't stop the medicine. If the child has any problem, please come to the hospital. Please come and meet us. We will find a solution for you. But stopping the medicine is not a solution. If the medicine is causing some side effect, we'll change the medicine. But don't stop the medicine. That message needs to be told to all parents. They have to be explained how they work and how it takes time for about 2 to 3 weeks for the drugs to settle in the system. But as I said, children do not have so many side effects, even though the tablets are very bitter, the syrups are very bitter. Importance of every dose and every time, and the timing of the dose is very important. Measurement of the dose is very important. All this needs to be explained to the caregiver. We need to explain what is resistance, what will happen if you don't take the tablets on time, if you don't take the medicine in right dosage, if you do not take it regularly, what will happen, what is resistance, this needs to be explained. And what are the other potential barriers? One is disclosure. Small children can be forced to eat the medicine how parents usually is, lamba hona hai, dawai kha lo. But once the child is adolescent, the child will say, I don't want to have any medicine. I've grown tall. I've grown this thing. Now I don't want to have medicine. Why should I have medicine? That is a time that disclosure is important. Maybe if you have a timely disclosure, child comes to know about the HIV infection and will continue to take the medicine. Second is food insecurity. You are giving ART, but you need to give children food also. If the child's parents do not have that much money to be able to afford a normal diet to these children, that can also be a potential barrier. Ki we don't have adequate amount of food, so let's miss the tablet. This happens in certain low socio-economic status HIV infected families. So this is very important. We must have a discussion, the counselor with the caregiver, identify the caregiver. We say that in children we should have 2 caregivers. If the parents are caregivers, when they fall ill, who will give the medicine to the child? So we have 2 caregivers. We have an alternate caregiver, which can be a grandmother, an aunt, or somebody who gives the medicine when the mother or the father falls ill. So in children we need to identify 2 caregivers. Who will give the medicine? What time will we give the medicine? What medication has to be given? What is the dosage of the medicine? We've had numerous occasions where you explain it to the person who comes to take the medicine, but you later realize that the person who's giving the medicine is not the person who's taking the medicine. Matlab, the caregiver who is gone to the pharmacy to collect the medicine goes home and hands over this medicine to the grandmother, who further doesn't understand what is the dosage, and instead of giving 2.5 tablets, thinks it's too higher dose to give, is giving 1.5 tablets. This is where non-adherence occurs in children. So communication should be directly to the caregiver, and if it is not to the caregiver, then make some diagrams or something which they can understand, or the grandmother can come once to understand once in 2 months, because she is the one who's giving the medicine. The father just goes to pick up the medicine and hands it over to the grandmother. So all these things need to be addressed, they need to be understood. How will the medicines be given? Will they remember? So what are reminders? Reminders are very important in children. What will happen if they go for a wedding? We've had non-adherence causes. We went to the wedding, didn't take the medicine, would have been disclosure. Because they will ask you, what is this bottle you're feeding? Why do you need to put this bottle in the fridge? All these issues are there. Then what is the plan if the child refuses and spits? Can anyone tell me what is to be done if the child vomits or refuses or spits? So within half an hour of taking the drug, if the child vomits, you don't need to repeat the dose. If beyond half an hour, if the child vomits, spits out the medicine within half an hour of taking the medication, you need to repeat the dose. But if it is half an hour, 1 hour beyond the time of medicine has been given to the child, you don't need to repeat the dose. But we usually advise that mothers, that because all the syrups and tablets are very bitter, that they should add sugar to the solution. So preferably give it with sugar solution, or keep something sweet in another katori with a spoon to give the child along with the medication, because these tablets and syrups are very, very bitter. Yes, Dr. Nazia, honey, but sometimes honey can also cause some kind of infections if it's not a sterile, in a sterile container. So we avoid giving honey. We usually say give it with sugar or some sugar solutions, or keep something sweet next to be given immediately after giving the medication, like a fruit or something. Pre-ART activities. So these are very important before you start ART. Do we do it? We don't do it in our country, but this is important. So what do? We have to teach a child more than 5 years of age how to swallow pills. So we need dummy pills to learn how to swallow them. Taste testing. You know, if you can taste it in front of a dummy's thing and just taste and say, okay, the taste is bitter, so now how do you explain to the child how to give it? And giving the first doses in clinic or hospital. These three activities, if we are able to do, will support the adherence in these children. Emphasize that it is a team effort. So it's a team effort of the caregiver, the parents, the child, and the counselor, and the doctor, and the ART team. Please do not pass any judgments or anything that, okay, you are not taking it, or you're a bad boy, or you're a bad girl, that you vomited the thing. Please tell the parents not to scare these children. If they vomit within a few minutes of taking the medicine, give a wait. Most children find it bitter and usually spit it out or vomit it immediately in 10-15 minutes. So give it a break. Take half an hour time for the child to settle down, and then again give the medicine. But yes, if the vomiting occurs after half an hour, you don't need to repeat the dose. Build a rapport with the family members so that they come running to you if there are problems. Most parents take their own decision of stopping the tablets when they have not built a rapport with the counselor. Discuss adherence at every visit. Remember what is adherence fatigue. Adherence fatigue is a very important, very important thing in children. Adherence fatigue is that initially the children are very happy in taking medicine because they are growing tall, they are putting on weight, they are able to play games, they are not getting infections, their hospital admissions have reduced. After 2 years, you will find that adherence fatigue starts coming in. That is, the parents have got tired of telling them, "Damai khao." The children have got tired of eating the medicine. They start questioning, why should I keep eating the medicine? And now I've grown tall, now I'm putting on weight, now I don't need to get injections, now I don't need to go to the hospital, I've become alright. So please be wary of adherence fatigue, which usually comes after second year of ART, and it's very important because this is a time when resistance may occur. Viral resistance may manifest. So what is mental health issues in perinatally infected children? This is what I was telling you. Most of the children who are in utero or perinatally infected children have a lot of mental health problems. They have a lot of emotional and behavioral problems. They have a lot of psychiatric issues and psychological issues. So please have a good contact in your psychiatric department, have a good contact with your psychologist in your hospital, because if you have small children, when they grow up to adolescent, you'll have all these issues and they need to be addressed properly. Along with this is that issue of disclosure. So both of them hand in hand cause a lot of emotional stress and behavioral problems in HIV infected adolescents. So I've come to the end of the presentation. Just a small summary of what is the pediatric HIV management. We may need to make a lot of effort to prevent infection in children. If we prevent infection in children, it will be ideal. If we can't prevent, or there is some child who's got infected, early diagnosis is what is attempted. It is challenging because at right blood spot, the PCR DNA reports take time to come. There is high early mortality, so starting ART before they become symptomatic or hospitalization is very important. First, mortality within first year of life is very high. There are a lot of disclosure and adherence issues which need to be addressed. So it is an ongoing counseling which is done for children, which may not be required in adults, but for children it's an ongoing counseling. And non-ART interventions are important. We need to remember that we need to look at the drug dosage, the ART drugs, depending on the weight gain, look for toxicities, look for resistance, and long-term outcomes are good. You need to tell the parents that if you start ART in time, the child can grow as good as a normal child. But for this, we need to have good adherence, and that is why it's important to explain to the parents that if you want the child to grow tall or gain weight as a normal non-infected child, we need to ensure that he has adequate nutrition and has adequate calories and nutritional requirements are met, plus adherence issues are addressed. So thank you so much for patiently listening to me. These were the resources. Any other questions? We can close the session if there are no more questions. Okay, thank you so much for being patiently listening and interacting and answering all the questions. All the best. I would like you to look at all the slides and do the quiz in time, and hopefully your slides will help you in scoring well in your quiz. All the best. Good luck.